Hi, everybody. Thank you guys so much for coming to today's webinar. It's entitled Road to Licensure, Setting the Foundation of Your Clinical Career, hosted by Motivo in partnership with our amazing partners, Capella University, who we do so much good work with, and we're just really appreciative of all they're doing to educate new therapists that are coming into the field. We have a great group of panelists for today. If you've been on these before, you might recognize some of the names, but I also just want to give a quick shout out to Andre, who's on our call. This is the first time that we've had a BCBA, a board certified behavior analyst, included in this discussion. Motivo recently expanded to providing BCBA supervision. We have about 100 BCBA supervisors across the country now providing supervision through Motivo. So we really wanted to let the learners and alumni of Capella know about that, because you guys have a really thriving BCBA program there as well. So again, welcome. Thank you for being here. And let's dive in. We have several questions that we want to address today, mainly around placement setting, clinical placement setting, clinical supervision, the licensure exam, and just the field trajectory. We would love to take your questions as well. Feel free to put them in chat. Feel free to say who you are and where you're typing in from. The panelists look at those and just make sure when you're chatting that you're sending it to everyone so that everybody can see it and we can answer questions there that, as you have them as well. So my name is Rachel McCrickard. I'm a licensed marriage and family therapist and an AAMFT approved supervisor. I'm also the CEO and founder of a company called Motivo, which is an online clinical supervision platform that's been up and running for a couple of years now, helping connect new graduates to a great clinical supervisor. We have nearly 1,000 clinical supervisors on our site, and they're all available for virtual supervision. And our rates, we think, are pretty reasonable as well. All of the panelists, except for Dr. Stanley, because he's quite busy being the dean at Capella, are supervisors on our site. You can find them there. So I want to allow each panelist to introduce themselves to you. Let's start with Dr. Stanley. Could you introduce yourself and share a little bit about your role at Capella?
Sure, absolutely. So it's great to see you all here. My name is Josh Stanley. As Rachel said, I have the privilege of serving as Dean for the School of Social and Behavioral Sciences at Capella University. That school encompasses our counseling, family therapy, clinical and school psychology, and ABA program. So it's really great to see you all here and be with you. My professional background is as a school counselor. So I spent most of my professional career before moving into higher ed, working in primarily elementary schools, actually, for about 5 years. And then I did a couple of years at a combined middle high school. Here in my city that I live in now, I also have a limited private practice on the side where I see clients mostly on Saturdays, focused on the LGBTQ population, individuals and couples as well. And so just glad to be with you and hope you enjoyed the webinar.
So you could do supervision on Saturday then. That's what I'm hearing. Okay, Dr. Smith, how about you?
Good afternoon, everyone, or morning or evening, where you are. I am Carla Smith. I am a licensed clinical social worker as well as a licensed marriage and family therapist. I am also a clinical supervisor, and I am in Atlanta, where I have a private practice, and I am also a diversity and inclusion consultant. So much of my work is really at the intersection of social advocacy and direct care for people in various communities. A lot of my work is really on culturally affirming practices, especially for marginalized populations. Most of my clients are Black individuals and couples, and so really working with trauma and healing around racial trauma, as well as personal and relational trauma as well.
Great, thank you so much for being here, Dr. Smith. Jason, how about you?
Hey everyone, my name is Jason Rodriguez. I'm a licensed professional counselor in the states of Georgia and South Carolina. I'm also a certified professional counselor supervisor in the state of Georgia. I am currently the director of community programs at an agency in Atlanta, Georgia called Hillside. We primarily provide residential services as well as community services to youth and families. And so the community programs I direct are anywhere between upstream prevention services to identify to assist with reducing risk factors and improving protective factors for specific communities, to virtual intensive outpatient programs for folks who have disparities in access for mental health services across the state of Georgia, and just more recently in Florida as well. And so we're kind of multi-states in that situation. And so I'm happy to be here. I'm happy to kind of be a resource for anyone looking for support. So.
Great to have you, Jason. Dr. Bronco, how about you?
Hi, everyone. I am Susan Branco, and I am located in Northern Virginia. I'm licensed as a professional counselor in Virginia as well as in Maryland. Currently, I'm a full-time assistant professor with St. Bonaventure University in their school counseling and clinical mental health counseling program. But prior to that role, I was in independent practice for many, many years and worked also in community mental health. And the population with whom I worked with most were people who were connected to adoption in some way. And mostly of that group, the clients I saw were transracially adopted. So my research focus continues to be transracial adoption, as well as training and supervision practices for counselors who are members of the BIPOC community.
That's great. Dr. Branco, I love that you have that experience in both private practice and community mental health, because I feel like there's such key differences, and we're going to get into that with our first question as well. Andre, how about you?
Hello, everybody. My name is Andre Anderson. I'm a board certified behavior analyst 2004. I'm just so happy to be here with other professionals because, you know, in the helping profession, you kind of fall into it. And before you know it, you become an expert somehow. I don't know what it is, but it is. First of all, with Motivo and also with Capella because of lifelong learning. So I am the chair of organization and partnerships at the ABA Task Force to eradicate social injustice. I know that's a real long name, but what we do is we try to help organizations, clinical professionals, especially in the ABA industry. I'm a subject matter expert with Truman State University, developing their ABA BACB compliance code, and their program is opening up in the fall of 2022. And then I'm also a supervisor and provide telehealth with a few agencies throughout the country. At this stage, I just turned 50 yesterday. I'm getting a whole bunch of belated messages. I don't know if people like me or hate me, but I'll take it, right? And tomorrow is my anniversary, so we call it birth anniversary. I'm just a real dude, and I care about the profession. I care about the helping profession. My lifelong goal and passion is my dissertation is on poetry self-care. I think that your playlists are magical for a reason more so than entertainment.
Gosh, that was powerful, wasn't it? Well, happy birthday to you, Andre, and so happy to have you here as our first BCBA panelist. And I see in the chats here too that there are some ABAs on the call, which is awesome. That's totally what we wanted. So wonderful. And I love what you said about lifelong learning. I feel like that's something that Capella talks, that we talk to them a lot about, this idea of like, your education doesn't end with graduation, like that. There has to be a commitment to continue to grow as a professional, mainly because new research is coming out all the time. So really, it's incumbent upon us to make sure that we stay relevant and know what's happening in the world. So let's dive into our first question, and this is about clinical setting. So a lot of times when when you're in grad school, you're already thinking about what place do I want to work? Do I want to work in private practice? Do I want to work in community mental health? Do I want to work in healthcare, hospitals? What do you want to do? A lot of times that's kind of mandated by your state, whether or not you can even be in private practice as a pre-licensed clinician under supervision. But even thinking beyond that to after you get licensed and you have kind of your pick of clinical setting. So I want to just have the panelists talk a little bit about what the differences are, some of the key differences between community mental health and private practice. What should our listeners be thinking about today? So Jason, can you start with that question?
Yeah, so I'm coming from an agency, and I've done most of my work within agencies, and I've done private practice on the sides and things like that over the course of my years. And so there are some differences in regards to like the expectations and what you can expect from it. In regards to the pros and cons of working within community health, the pros, like clinical supervision, most community health organizations provide free clinical supervision for their employees. A lot of the times that includes like contracts and stuff like that. So if we provide you with supervision over the course of your 2 years or 3 years that you need it, you're contracted to kind of stay with us for another 2 years or so upon the completion. It's just that's normal process. But at the same time, it's nice that you don't have to go out of your pocket for that. You get clinical training. Most of the work that's done within agencies are evidence-based practices. And a lot of the times, particular evidence-based practices are pretty costly to get trained in and time-consuming to get trained in. And there are a lot of resources that are needed for you to be able to be trained and certified in those. And so if you work with an agency that's connected to a specific type of evidence-based practice, a lot of the times that training comes along with it. So that's a benefit from it. Outside of just the administrative support, a lot of the times you don't have to worry about collecting, you don't have to worry about billing, you don't have to worry too much about utilization reviews other than getting your notes in to make sure that the person who does the utilization reviews has those. And so a lot of the times that's a really big plus. So you can really focus on your clinical work without necessarily being terribly overridden with administrative burdens and things off to the side that don't necessarily have to do with like clinical work. Another good thing is that you have exposure to a lot of mental health difficulties if that's what you're looking for. You don't necessarily have to always, I guess, market for cases. They just kind of show up for you, and unless you're seeking for that you're looking for that kind of exposure and that experience. You have leadership opportunities. You'll be able to see what it's like to be a supervisor or a manager of a program and things like that. And so a lot of people find that really exciting. I know I did, and of course benefits. A lot if you're working in private practice, sometimes having health insurance and vision insurance and all that stuff, so it can get a little rocky. And so it's nice to be able to know that you're secure in regards to benefits and all that's concerned. And so those are all pluses. Like cons are that, a lot of the times when you work with agencies, it's a lot of volume. So you will have cases and the expectation is that you work through those cases as efficiently and as effectively as you can. The cons is that sometimes some programs and some programming is highly focused on, rather than like therapeutic progress, it's focused on mitigating risk and reducing liability. And so like whenever you're like speaking to agencies and things of that nature, it's good for you to kind of know, hey, where does this agency stand? Does this align with me? Am I okay with working and doing a lot of risk containment and crisis intervention work, which in itself can be very exciting and rewarding and all of that stuff. And at the same time, if you're going in thinking that you're going to do long-term therapies and things like that, it becomes a very quick like awakening, but outside of that, I mean, there are pros and cons with working in the community and different settings and different agencies and hospitals and things of that nature. It's just the general pros are very specific, and the general cons kind of go hand in hand with those pros as well. So it's really up to your preferences in regards to what you're looking for experiences.
Well said, Jason. I think you hit the pros and cons on both sides really well. Dr. Branco, I'd love for you to just elaborate on that, maybe even speaking a little bit about the turnover that happens within community mental health care and why that might be, and what we could think about doing about that.
Sure.
Big problem to solve there. Just go ahead.
Yeah, right. I can do it in 3 minutes or less. I agree with everything you said, Jason. I started in community mental health, and what I often share with my supervisees is I would not have gone into independent practice if I did not have that rich experience in community mental health first. It really helped me. It still helps me to this day. Didn't mention earlier, I'm still doing community mental health, but on a pro bono basis. So now I'm seeing clients who speak Spanish as their first or perhaps second language, but they don't speak English. So that knowledge really helped me to do something I really enjoy. However, to your question, Rachel, in regard to the turnover, I think Jason hit on that pretty well when you talked about volume. There is unending need in community mental health. There's always going to be a waiting list. You're always next in line, and you don't have a lot of say for the type of client that you will receive. You kind of see whoever's next, and if it's your day to see that person, that's on you. And there often tends to be complex cases. These are not like, I don't know if this phrase is still used and I don't particularly like it, but I'll say it like the worried well. These are clients that have lots of concerns, a lot to do with systemic issues, systemic oppression, marginalization, financial concerns, and it's all on you. And usually you work in a team, but it's very quick paced and there's often not a lot of time to even, I remember like having the lunch break was not something that happened too frequently. Using the restroom wasn't something that these things became luxury. So it gets very easy to get into a routine of really always being on the go and having to meet certain markers, benchmarks that each agency delineates. So what I saw, and I was doing this a while ago, is that people would often kind of start getting burnt out, but feel somewhat trapped to leave because of the other things Jason mentioned, the benefits, the pay scales, the fear of leaving. And that it was around that time I determined that I did not want to be that way for the rest of my career, because we all go into this career to really give back to our community, and it can be very fulfilling, but not if you're burnt out or suffering from vicarious trauma. So for that reason, I kind of made the hard pivot to independent practice, and I did not have benefits. I worked 6 days a week for about 15 years. I didn't take a lot of vacations. So it's a whole different type of stress. But then you're able to kind of filter what kind of client you'd like to work with to some extent, not completely.
Well said. Thank you for that, Dr. Branco. I mean, I think too, just wrapping up some of the conversation on community mental health, we're going to look at a few other different clinical settings with the other panelists. But, my thought too, when I worked in it was, these are individuals who would never darken the door of a private practice therapist's office, right? Like they just don't have the resources to be able to do that. A lot of times they didn't have even transportation, so you're right. So many of us get into this field to make a difference, but I love what you've done there with the pro bono work, because I think that's a great way to still give back to the profession, still kind of do the work that inspires you, and also be able to, make a living as well. So I think that's a creative solution for that. Moving on, let's go to Dr. Smith. You have created, you're an entrepreneur of, creating your own private practice, creating your own business consultancy for diversity, equity, and inclusion. What have you learned about charting that course?
Well, similar to what we were just talking about, I've learned that, you really do need a broad range of experience in order to then know where you best serve. And so another thing that community mental health does that Jason and Dr. Branco already said was that it exposes you to diversity. And it's not just racial diversity, it's not just class diversity. We're also looking at the most underserved populations that in our country, in our states, in the counties that we will be eventually working. So community mental health does that. I think working at hospitals do that as well. And in addition, I worked for hospice, which was one of the last things that I would have ever done, but it was also the most rewarding. And so to be able to learn about grief, through that process, and to learn how to work with families throughout the stages of loss and someone's death and prognosis with their illnesses, I think is a learning experience that I would have never said leaving graduate school that that's something that I want to do. So it is very important to have that just diversity of experience and knowledge. And even if you find out, you go into community mental health and you find out that it's not what you want to do, for your whole career, you at least can say, I'm going to identify a goal. And one of the goals that I set at that time was to really be able to work within Black communities, which was one of the things that I went to graduate school for, and to learn more about what the needs are, especially based in mental health and mental health disparities. So we can actually learn a great deal, and also learn how to what our specific needs are when it comes to self-care. Burnout is not something that we have to experience in community mental health, but it's a learning experience for ourselves to be self-aware and to know, maybe I can't have 40 clients on my caseload, but maybe I can do it part-time. Maybe now we have a lot more community mental health that are doing telehealth, and what does that mean? But to expose yourself to a person's environment and the various systems that they're a part of, to really experience that with them, is something that makes a considerable difference in our ability to connect with them and build the relationship where change can occur. So I really do appreciate the, just having all of that experience and then being able to funnel down through all of those different jobs that I've had of not just my ideal client, but what am I passionate about? Where am I best able to serve, and to serve specifically mental health, the needs of underserved populations.
So well said. I love that. Yeah, there's so many skills that we can learn in so many different environments that apply to other ones. That's such a great point. Andre, I'm excited to ask you this question because I don't know much about BCBA. I'm still learning about the applied behavior analysis field. And so I'd love your thoughts on what kinds of clinical settings are great for BCBAs. What should they be thinking about?
Yeah, so 73% of service delivery in ABA is with autism. And I choose, even the way that I said that kind of sounded mechanical, because there's the whole move of person-centered versus identity-centered language, right? It's autistic, person or person with autism. And so that you'll easily get your feet wet inside of the autism industry. Now, I've been completely blessed. And geez, I started in the early 90s. I'm dating myself, but I was at a group home where it was 8 individuals to 2 staff persons. And back then it was almost taboo to get the diagnosis, because inadvertently you would not get insurance coverage, because autism is a neurological disorder, no known cause, no known cure. So you'd have to do this song and dance as far as what type of, and all of our clinicians, the entire industry knew it. Well, when you have the confluence of Autism Speaks and insurance reform, and it's so many different nuances that, again, the confluence, the building together. So finally our folks, our autistic industry is having those services. So as potential certificate seekers, get your feet wet. The autistic industry is a blessed industry, in my humble opinion. The diagnostic criteria, I could go through all of that. But most importantly, you'll get to see how families operate and learn. And that's why, again, Motivo and Capella being together, because to have Dr. Smith, Dr. Branco on this call, there's more than one way to skin a cat. As an ABA therapist, I'm looking at antecedent behavior consequences. It can feel mechanical. And most folks don't come out the womb negotiating with their child. I didn't grow up like that. However, were my hook with families, especially with kids on autism, we know that evidence-based ABA has so much research and effectiveness in reducing problematic behavior and increasing socially acceptable behavior. I'm sorry, that's a mouthful. But your industry of autism, my asterisk, go in with that spirit of gratitude and humility, because it's inevitable that you're going to be frustrated just with learning. But go in with that humble, that cultural humility, because when you start seeing kids who are nonverbal or smearing or eloping, and you put a behavior plan, an assessment and plan together, and then execute that bad boy, and you see effectiveness, I don't know if there's a greater joy I've ever experienced. It's amazing. It's really amazing. But you're also going to be supervising others, and they're also doing parent training. It's a unique model. So you're going to get your feet wet more than likely in the autistic industry.
Great words there. It makes me think about the fact that what I have found in any industry, really, not just therapy, but that one of the biggest predictors of burnout, I think, is not being able to see the impact of your work. A lot of people don't mind working really hard, but to work really, really hard and not see any impact of it, I think, is what can really lead people to burnout. So I really loved the way that you framed just the beauty of the work, of being able to see the direct impact of it and see it help children. That was just really well said. Thank you for that.
Thank you.
Yeah. Dr. Stanley, would love to hear about your perspective on this, particularly with all of your school-based experience. Can you talk a little bit about that?
Yeah, sure, absolutely. So, I would say that the interesting thing about all of the professionals on the call today is all of us can actually work in a school setting, as well as a community mental health setting or a private practice. And then that also includes school counselors as well. When I was when I think about the settings, I remember early in my career, I was just dead set on being a high school counselor. I loved it. I really wanted to work with the post-secondary piece. Focusing most heavily on career counseling was my jam. But the year I graduated, there were only openings at the elementary level. And so when you're first, somebody else said this already, but it's keep yourself open. And I think that's definitely true in the school setting. There's nothing inherently similar about working with a 7-year-old and a 17-year-old. So if you don't have diverse experiences as part of your training, you may be limiting future employment opportunities. I was very fortunate because I had done an internship at both the elementary level and the secondary level and felt pretty prepared. But the other thing that and then I should close the loop on that. I ended up loving it and stayed at the elementary level. So one of the things that I would strongly recommend, as I said, is just to diversify your experiences. Don't work with just one population. Don't work with just one presenting condition or presenting whatever population you're trying to serve. And I would suggest that across all the disciplines. I think even in private practice, I've developed a niche for myself. It sounds like most of the people on the call have developed a niche, but I'm glad to have had that general training in the beginning that allowed me to develop my niche rather than doing it the opposite direction. The other thing that I would say about schools is they are a microcosm of society. So it's a really good place to get a lot of experience. I feel like you definitely see the systemic perspective in schools. It is a place that is prime for systemic thinking. You're able to influence not only the individual, but larger systems and structures as well. That's super rewarding. And then the last thing I will say is, in the unfortunate reality in which we live, where due to certain crises in schools, we've seen the emphasis on how much need there is for mental health for children and adolescents. The door is really wide open through state and federal funding for, again, all of the helping professions represented today to really provide extended access to children and adolescents through the school setting, whether it's a clinical mental health counselor, marriage and family therapist, behavior analyst, or a school counselor. So try a school, you might like it.
One of the things too I want to mention there is that I think if I wouldn't have known much about the profession coming into it, I would have thought that school setting means school counselor, and that's all it means, right? But it doesn't. There's a lot of ways to work in schools, not working directly for the school. When I worked at Georgia Hope, I helped create the school-based mental health program under the APEX grant for Georgia. This was funding specifically earmarked for placing community mental health therapists in the schools for billable hours with the Medicaid and uninsured population. And, we got to be school-based therapists without working as a school counselor. So there's a lot of variety there, I think, that people don't often think about. So let's get into clinical supervision a little bit, something that I'm super passionate about. Maybe I'll just quickly say that the word motivo means foundation in Portuguese. And I picked the name for motivo with intention because I thought, clinical supervision is really the basis of your clinical career. You go to school, and then as you begin seeing clients, you don't know what you're doing. I can remember being very scared about what I was doing and really needed someone to hold my hand throughout that process. And I think too often we view supervision as a box to check. I can remember thinking just get it done. I'll worry about my clinical training later. I'll worry about becoming a great therapist when I'm actually making enough money to think about that. And I really I think missed out on some early opportunities to get really great clinical supervision, either advocating for it within my agency or paying a little bit outside to supplement the supervision that I was getting from my community mental health setting. But I think that there is really good reason to invest in yourself and invest in your own clinical development. So let's talk about that a little bit with our panelists. Dr. Smith, I want to ask you to start mainly thinking about clinical supervision versus administrative supervision. What are those two terms? What do they mean?
Administrative supervision is the supervision you get, as a part of your employment. You could also be, a contractor. You basically are assigned a supervisor, a person who does the supervision of the pre-license folks at the place where you are working and getting paid. That usually is kind of through the lens of, as Jason said earlier, kind of keeping liability down, making sure that you are getting your notes in the appropriate amount of time, that they look the way that they're supposed to in order to bill insurance. There's going to be a lot of discussions about what the boundaries are for the third-party payers. So if the insurance company says you have to do a certain thing with particular clients, then that's what you have to do. And so your supervisor is going to kind of have that lens. Also, they're most likely going to have the lens of, if there is something that you've done that needs to kind of be corrected or remediated with a client, then they're also going to have that responsibility also. There may be other people, clinical director, that may also have some say there in situations like that. But that supervisor is just going to have the lens of, they are representative of the company or the organization that you're working with, and they are providing you supervision on how to actually take care of the clients and the caseload that you have. There may be times that supervisor has kind of a personal interest in your trajectory or your journey. but it is not a requirement for the most part. They really do need to make sure that you as an employee or a contractor are doing the job. And so they do that. The outside clinical supervisor is going to be usually, because they are not connected to the organization that you're working with, they're usually just focused on you. Now, they are definitely going to be talking to you about your cases. You're going to be doing case consultation, asking questions. They might have a requirement of seeing you do the work that you do, or going over your notes if that's part of the supervision with them. But for the most part, they're going to be a resource that is helping your professional development into, whatever the next stage is. They can help you with licensure prep. They can help you with kind of creating your journey. They can also help you with advocacy. So again, as an outside person, you may say that there's something going on at the agency or at the place where you are seeing clients, and they can help you either, advocate for yourself, or they can come in as an outside person and just kind of be a support for you to help use your voice. I think one of the things that is also really important, as Rachel was kind of talking about, why it might be important to have both. Like if you get free supervision with your agency, by all means do that. But that also you might want to 1 hour a month or 2 hours a month, if you can afford it, get an outside supervisor, because together you will then be able to have support for your clients, but then also support for you. And I find that an outside supervisor can really help you with finding your voice and establishing the voice that you need in order to advocate for yourself and for your clients. The mental health system in the United States specifically, but I would also argue globally, is one that needs a lot of work, and our clients need advocates. And so as an intermediary, as a person who, kind of works with them and sees what's going on, but then also insurance companies who don't actually see what's going on, or, the education system or something like that, we have a lot of the language and the ability to advocate and to stand with our families and our clients. And that takes developing a voice, that takes developing security in knowing that you are, saying the right thing and doing the right thing, even if there is pushback. And so then what do you do? What do you do as a pre-licensed person to use that voice and to use that position and to use the privilege that you have to be able to also stand with your clients? And that's a really important aspect. Creating your voice also helps later on, your ideal client and what do you want to do. And if you're the person owning the business, you're the person that also has to step up and be the person who is speaking for and with. And so clinical supervision is where you can actually start to do that and really, state your claim as a clinician, as a therapist, wherever you are.
I love that advocacy piece. That's so great. Dr. Branco, what would you add to this? What are some of the barriers around clinical supervision that you've observed?
Oh, there's so many, but not as many as when I was starting. So accessibility, initially there were not as many LPCs in different states to be able to provide the supervision that was needed. And then the barrier became, do they meet the requirements for supervision? Do they have the supervision training or the certification? And are they within like a distance that I could get to once a week? And then it became, are they affordable? Because like Dr. Smith was saying, you may have admin supervision, but many people want that extra type of supervision. And sometimes having that kind of supervision 4 times a month can be really challenging. So what I'm seeing now is that I've experienced as a supervisor here with Motivo much more accessibility for supervision and also more choice. So supervisees have a chance to really vet out who might be the best fit for them right now. But with that being said, I think it's important too that we mentioned the supervisory and supervisor relationship really does need to be similar in terms of how you are with clients. Sometimes it's not a good fit. And we need to allow ourselves that chance to be able to determine, is this a good fit? How are we building that relationship as a supervisor? How are we broaching different salient identities? How are we including that in our supervision? Because it needs to be a safe relationship, because our supervisees need to be able to feel comfortable to share with us barriers that they might face in clinical practice so that we can support them and that we're helping care for their clients at the same time.
So well said. I'm sorry, I never let me drink this again before I lead a panel, because I had to run to the bathroom like so quick. But I heard everything that you said, Dr. Branco, and I think that is so well said. And so Dr. Stanley, let's talk a little bit about barriers that you have heard people talk about, particularly from your students as they're just starting out regarding supervision.
I think I'll be quick. I know we don't have a ton of time, but I think the biggest barrier from the student perspective is just finding a site and a supervisor to begin with for that pre-master's internship. And so, on that note, I would just say start early, look early. There are resources that I think sometimes maybe they're not well advertised or they're a little bit hidden. But if you're a Capella student right now, you can talk to your faculty advisor or your academic coach. We have a list of all the sites that have previously hosted interns by state. And so that's a good place to start if you're not sure where to go. Even if that person is full, maybe there's somebody else that works there. So it can be a good foot in the door. The other thing that I would say is when you have the option, make sure that your clinical supervisor is a good fit for you. And when I say that, know what type of supervision you're looking for, and then share that with your clinical supervisor. Know that the clinical supervision relationship will evolve over time, and it should, but make sure you're communicating with your clinical supervisor what you'd like to see. And then one thing, being the school counselor, right? One thing I will add is in school counseling, there are no postmaster's supervision requirements. I think that's a tragedy. Because I certainly would, every year that I practiced in the field, new things were happening all the time. So I would like to encourage that notion of voluntary clinical supervision or consultation. Maybe it's you and a colleague that do it for each other, but always have that person that you can go to for a consultation, because you're going to have cases 10, 15, 20 years in that still are still difficult and you need to process. So that would be my take.
I love that. Yeah, I like calling that too restorative supervision. Just the idea that you're not doing it in pursuit of a license necessarily. You're doing it for your own clinical development, and that can happen while you're pre-licensed or after. Jason, I'd love to hear your thoughts on this, particularly some of the stuff that Dr. Stanley said regarding like advocacy for yourself. Like if Hillsides provides great clinical supervision, but how could someone who's working in a community mental health setting, what would be the conversation they would have with their clinical director if they felt like they weren't getting adequate supervision?
Yeah, I think you just have to be honest and also know where you are. A lot of agencies have the agency in mind whenever they're developing people and therapists. And so they want these therapists within their agency to be good agency therapists, not therapists that they want to be, if that makes sense. A lot of the times, not all the time, but a lot of the times. And so a lot of the development will move towards that direction, and that's not necessarily a bad thing, particularly if it greatly aligns with your expectations. So if you really want to be a DBT therapist, like Hillside will get you there. You will get there quickly, and you will get a lot of experience and a lot of exposure and a lot of training, and that is awesome. And if that's not your jam, it's going to feel a little bit alienating and frustrating, and it feels as if you're a bit isolated. And so a lot of agencies really kind of focus on the evidence-based practices that they tend to kind of lean on. There are several out there that are very common that agencies kind of focus on trainings, and that like also kind of bleeds into like what type of supervision you receive, you know. And so like supervision can be embedded into the programs. And so it does bleed to, like Dr. Smith expressed, it bleeds into that administrative supervision, you know. And sometimes like the times you want to develop as an individual therapist turns into, you know, working towards being that agency therapist. And sometimes that doesn't necessarily feel the best. And so a lot of times it sounds like it feels as if like your interventions, or not interventions, your meetings tend to be more outcome focused rather than development focused, you know. And so, hey, when's the discharge plan for the discharge date for this kid? You know, have you met all the criteria for your treatment plans? You know, like this, that, and the other. And it ends up being more about like, hey, what's going on with this case, rather than, hey, how did you get there? Or what do you feel like you need in order to get there more effectively or more efficiently, or anything like that. And so sometimes it feels less individualized and more like validity checks, you know, versus development. And, you know, and sometimes you just have to kind of be aware of where you are in regards to your development, you know, and your supervisor as well. Some supervisors tend to be more oriented towards the administrative tasks and needs of the agency rather than your personal development. And so they should be open to kind of having those discussions with you on like a monthly to bi-monthly basis or so. But really, if you're not getting there, you know, just make sure that you have like good contacts within the agency to be able to kind of advocate for yourself in that sense. So yeah, but otherwise, like I said, I mean, like, getting supervision from an agency, it sounds all like, ooh, that sounds a bit scary, but very, very honestly, like if it really does align with your needs and wants, you know, like if you want to work with kids and families, you would get amazing supervision from most agencies that work with kids and families. You know, that's fantastic. So, but it's really up to you to make sure that you steer it in the right direction whenever it kind of goes askew.
Yeah. You know, I think it's also helpful to know as a student or a recent alumni the business model of community mental health agencies. They don't like not invest in their employees because they don't want to. A lot of times it is just that, you know, they are only paid for their reimbursable hours. Like their billable time is the only time that this agency is getting any funds in the door. So of course, they're thinking about volume and how many clients can be seen for a number of hours. So I just wanted to highlight a new model that has been developing over the last couple of years. If you ever heard of federally qualified healthcare centers, this is like the behavioral health side of this. They're called CCBHCs. And I'm just going to put a link to them here, because here's the interesting thing about them. There's about 400 of them across the US now. They get extra funding to serve like the whole employee. So they can bid for extra funding from the state to cover things like better supervision, better training, covering the cost of the EHR, your electronic health record, those types of things. I think this is a model that I would love to see implemented more. There's more of these all the time. A number of the agencies we work with at Motivo are already CCBHCs, but I thought I'd just put them there as well. If you're looking for a place that might have more funding for particular kinds of services, it could be a good one to check out. Okay, let's end up the supervision conversation with Andre talking about BCBA supervision. What do we need to know about that, Andre?
Something that's fantastic. In 2022, our board developed a new handbook. So you want to get very familiar with it. Just go to www.bacb.com. But and so you have to have 2,000 supervised hours or 1,500 concentrated supervised hours. Because the landscape of BCBAs has changed so much, they're now requiring, if you're a BCBA with less than 1 year of experience, that you have to have a consultation supervisor. So that's something that Capella and Motivo kind of want to be keep on your palette. And that consultation supervisor has taken 8 hours of supervision and has at least 5 years of experience. You have to meet with that person once a month. So they're building in and projecting how to make sure we get good product out of the BCBAs who are going to be in the field. So that's really it in a nutshell. 2,000 hours supervised experience or 1,500 concentrated supervised experience. And that 2,000, you got to have 5% where you're supervised by BCBA, and then the concentrated, you have to have 10%. Those are like the nuts and bolts of it. I'd make sure platforms like this give you the opportunity to meet with the supervisor who's really, I'd like to say, of a diverse background, at least exposed to other practitioners who can help you develop a global worldview. I'd like to say a growth mindset when it comes to ABA. You can't count on just your community center. Don't limit yourself based on geography when it comes to shaping this industry. You want to connect early. And then not be the logic bully either. You're really developing your career and also pushing the industry forward too. So I pull from folks like Adam Grant. There's a plethora out there. Start tweaking your LinkedIn profile now. That's why. And while we were on here, I'm hitting up Dr. Smith, I'm hitting up Jason, I'm hitting up Dr. Branco, because you want to develop that cadre of professionals as you go forward.
Mm-hmm. Love that. Also, if you want to know more about Motivo's supervision for BCBAs, Hannah, I can tell that you're on this call, or I think also Autumn and Hannah. They are our two Motivo ABA program developers. If you guys could put your email in the chat there for everybody, would love for people to be able to reach out to you if they have more questions about BCBA supervision at Motivo. So we only have a few minutes left, and actually Dr. Smith has to drop off the call a little bit early for a client. So here's what I'd like to do next. I'd like to wrap up the discussion with some conversation around the licensure exam. But at the same time, I'd love for the panelists to put any resources, any links to resources in the chat for people to have there. So if there's anything you can think of that would have been helpful for you when you were starting out, please put it there so that people can look into those resources. But let's go ahead and talk a little bit about the licensure exam. So Andre, maybe we'll start with you. Could you tell us a little bit about the exam that BCBAs take?
All right, I'm just going to talk straight. Most folks that I know failed it. It's difficult. Because with ABA, you're looking, I mean, it's single subject design meets group contingency. You are literally developing an entirely different paradigm and language. It's not easy, but I did pass on the first go around, and what we use at Truman State and what I used back in the early 2000s was BDS, Behavior Development Solutions, has a back then it was disc, and now it's just downloads. But go ahead, Google Behavior Development Solutions, ABA. I want to say their practice exams. So it gives you it trains you to fluency, because you're going to be going through so many different scenarios, whether it's ethics, again, single subject design, behavior change methods, overview, the law of effect, our assumptions. And so again, and they're not paying me to say this, I'm just giving you a nugget for free. Go ahead and check out Behavior Development Solutions packet on ABA licensure exam. You'd be doing yourself a favor.
Thank you for that, Andre. What about you, Jason?
Yeah, so I was able to, I took the NCE in 2009. So it's been a little while, but I think I was able to use the Encyclopedia of Counseling. It's by Rosenthal. It's a purple book. That's what I used for studying. The NCE is basically it's more about like the concept of counseling and the idea of counseling rather than actual like skills, at least from what I remember. And the Encyclopedia of Counseling helped like me memorize and have that route knowledge of those topics that were a little bit less on the front of my brain. Like for instance, like career counseling, like topics and things like that weren't necessarily something I focused on whenever I was, in my graduate program. So that helped me kind of keep that fresh, so that whenever I took the test, it was there and I was able to access it. And so really it's just being able to to go through the resources that you have, like the Encyclopedia of Counseling and any other kind of test prep book, to know the types of questions being asked and how they're being asked, and so how to take those tests, the multiple choice tests and stuff like that. And so other than that, the NCE is just, it is about information and facts about counseling and things like that. You don't have to necessarily think too hard into it. There is a right answer and a wrong answer in that case. Yeah, that's kind of what I have for the NCE.
Good advice there. Dr. Smith, I'm realizing I should have gone to you first because you have to jump off so early.
Okay, I did put some resources in the chat. So for social workers, there are actually various exams. If you have a BSW, there is a bachelor's level exam. If you have attained your master's degree, there's an LMSW. And then if you, after you spend some time in the field, depending on your state, it's different, then you can take the LCSW. So there are some differences, and really what it is, what are they, they're testing you on what the information, the knowledge that you were supposed to gain before that. So for example, for the LMSW, they want to know what do you know from your master's program? And your master's program is going to give you, just as much information as is in the field. So there's diverse types of topics. And then for MFTs, again, it's dependent upon your state, but there is a national exam. It's dependent upon your state as to when you can take the exam, but there is a national exam that you can take, and that you can take, again, dependent upon your state, either after you graduate or once you have gotten some clinical experience in clinical supervision. So really what you want to do is you want to start with both your state. You want to make sure that you understand what the requirements are for your state. MFTs, for example, COAMPT, which is the Council on Education, MFT Education, has just changed some of the language and the number of hours for MFT education. And that does not necessarily mean that the states have changed their threshold for hours. However, the states do have some flexibility on what those hours can look like. So, definitely connect to your state. I saw that there was a question about Georgia, and the board actually does allow you to count your supervision hours, so within the 400-hour minimum. You definitely want to look at that, and you want to actually get an understanding for yourself. So whether that be calling the board, talking to Motivo, who has office hours around state licensure, and how to really understand, or at least go through and find where the guidelines are and where the rules are. Definitely do that first, then go to the actual organization that created your exam. So there's ASWB and then the AMFTE. And so those are two organizations that are actually in control of the exam. So you need to know from them what is on it. What should you know? What are some topic areas, the types of questions? They might even tell you how to study. And then there are the paid resources, and I put the two that I used for my exams. But I think a clinical supervisor, an alum, someone who is licensed and who has gone through the program that you have, are really great resources to connect with, to just kind of like get information. You want to get as much information as possible, and from the direct sources as much as possible. Thank you, everyone. I do have to hop off.
Go right ahead, Dr. Smith. Thank you. I just am collecting all these resources that they're posting about, and I'll include all of them in the follow-up email. So I've got those links here. So Dr. Branco, maybe you could give us a few last words around licensure exams.
Sure. I would encourage, if you are in a KCREP accredited program, sometimes as a master's student for counseling, you are able to take the exam before you graduate. And I urge everyone who has that option to do it, because I took the exam when I was in my doctoral program, and it wasn't easy. I'm not going to say that, but I had all the information fresh in my head. So I would urge people to do that, and know that there is a practice exam that some states still do offer for counselors, and that's more of an application. So that requires a whole different set of study skills about how you would apply rather than just knowledge.
We're thinking about doing a whole session just on studying for the licensure exam. So look for information on that coming up. Dr. Stanley, I'm going to let you close this out here because I think you had a few thoughts to offer as well.
Sure, absolutely. Well, first, I want to just say thank you, Rachel, to you and Motivo for hosting this. Want to say thank you to all my fellow panelists. It's been great spending some time here. I wanted to just speak real quickly because I know that there were a few very learner-specific or state-specific issues that came up today. And I don't want you to feel like if you're a Capella student or alum that you're on your own. Obviously, the best place to go and the source of truth is always the state board. But if you are feeling lost and not sure where to start, you can reach out to your academic coach and start with them. They'll get you to the right place. If you're a counseling learner or a family therapy learner, we have faculty advisors who are members of the faculty who serve in an advising role as well. You can reach out to that person. But the big thing is don't just sit there at home if you have some confusion or stress about internship or licensure as you leave this meeting. Reach out and we'll get you to the right person who can provide some support. Okay?
Thank you. Love that. Thanks for that, Dr. Stanley. Yes, we recorded it and we saved the resources. So I'll be sending that in a follow-up email today. And thanks everybody for being here. Thank you especially to our panelists for just such wise words and sharing them with us. So I hope everyone has a good rest of your day. And yeah, take care. Bye, guys.
Bye-bye.